today we are going to talk about Digitalis in detail, right? Digitalis is a group of compounds which increase contractility of the heart, right? And this group of compounds, because they increase the strength of contractility of myocardium, these drugs are called positive inotropic drugs, right? Out of this group, two are commonly used. Out of this group, one is digoxin, and other is, yes, digitoxin. Digoxin. What do you think? Which should be used more? Digoxin is used much more, right? It has some advantages over digitoxin, and it is very commonly used, right? This, if you have to use a Digitalis group of drugs, the preferred choice is digoxin, right? You must be knowing why it is preferred over digitoxin. Okay. Do you know which one has short half-life and which has long half-life? Because if you have, which one is the one which has short half-life, that has less chances of toxicity. So can you tell me out of them which has short half-life, which has long half-life? How you know it? Yeah, the simplest thing, it's even spellings are less. The drug with less spellings has short half-life, and drug which has longer spellings, it has longer half-life. So there are advantages. The digoxin has shorter half-life. For example, it is only 36 hours, right? Or you can say 1.5 day. And digitoxin has a half-life of 5 days. Then which will start action earlier? The smart one. This is the smart one. It has less spellings, right? That has more spellings. So its action start, mechanism of action start, if you give this drug, it starts its action around 20 minutes, within 20 minutes. And this start its action about after 60 minutes. Right? Then protein binding. Of course, which has short half-life should bind to protein less. Which has long half-life, it means it is sticking to plasma proteins more, right? So it binds with the plasma protein about 30% of it. Plasma protein binding. And here, the plasma protein binding is about 90%. And then there's a very important difference. Digoxin goes out through rapid pathway, through renal, right? Its clearance is, it goes, renal excretion. It is freely filtered in glomeruli. But digitoxin, digitoxin has longer spelling. So you have to remember, look here, digitoxin has longer spellings, so it has longer half-life. It takes longer time to start its action. Digitoxin more strongly binds with plasma protein, and because digitoxin has more spelling, just a funny way to remember, it should need a bigger organ to go out. What do you think? Kidney is bigger or liver is bigger?
Kidney.
Liver is a larger organ. So actually, the digitoxin has to go out through hepatobiliary system. So it first gets metabolized there, and after that it goes out through hepatobiliary system and of course through GIT. This point is important clinically because that preferred, if you have to use the Digitalis group of drugs, the preferred drug is digoxin. It's a smarter drug, right? Shorter duration of, shorter you can say half-life, faster onset of action, less protein binding, and cleared through kidney. Other drug, digitoxin, look at it. In its name it is written that it can be acting as a toxin. Is that right? Digitoxin. You don't find toxin in the digoxin, do you? So whenever you see digoxin and digitoxin, toxin within the digitoxin should remind you it can produce more toxic and complications. So usually it is avoided. So when we really use this drug, second line drug, only when patient has significant renal problems. If someone has chronic renal failure and you really need to digitalize the patient, then you should prefer digitoxin. Only when patient has chronic renal failure. If patient has relatively good functioning kidney, digoxin should be the drug of choice, right? Then how the digoxin produces positive inotropy, we have already discussed very briefly. We will review it. So what really happens? Basically, there are in the myocardial cell membrane, there are special type of pumps, and these pumps are sodium-potassium ATPases. What is it? Look here. This is sodium-potassium ATPase. It is doing primary active transport or secondary active transport, just for a basic concept. This is doing primary active transport or secondary active transport? It is primary, because whenever there is active transport using the ATP directly, that is primary active transport. Normally, so what it is doing? It is taking the sodium out and bringing the potassium in. Is that right? What we discussed that Digitalis, this is Digitalis. It binds over this pump. I think it's sitting in a very awkward position. It sits on this pump. When Digitalis sits on this pump will work fast or slow? Slow. So what really happens that when Digitalis is binding the sodium-potassium ATPases, there is intracellular sodium accumulation, right? Intracellular sodium increased, right? That will lead to after digitalization, intracellular sodium will increase. And when intracellular sodium is increased, now we have to remember there is a special exchanger. And what is this exchanger doing? Yes, this is you can say sodium calcium exchanger. Normally it allows sodium to come in and it allows the calcium to go out. Is that right? When it is formed, this exchanger, when this exchanger is working, it is bringing the sodium in and taking the calcium out. Now, the performance of this exchanger, listen very carefully, the performance of this exchanger depends on that how fast sodium is coming in. Is that right? It means it depends on the gradient of sodium, concentration gradient in extracellular and intracellular sodium. When you have digitalized the patient, intracellular sodium is more. There is increased intracellular sodium. When intracellular sodium is there is already extra sodium. Do you think sodium will love to come in? No. So there is reduced gradient for the sodium to move from extracellular environment to intracellular area. When there is reduced movement of the sodium, right, that will reduce the total activity of this exchanger. So naturally, when less sodium is coming in through this exchanger, there will be less calcium going out through this exchanger, right? Now, so in this way, blocking the sodium-potassium ATPase primarily increases intracellular sodium, but when intracellular sodium is more, that fills the exchanger and that secondarily increases intracellular calcium. And this calcium, which is unable to go out, is captured by special intracellular apparatus. What is this? Sarcoplasmic reticulum. And what this apparatus will love to do, that it has special type of calcium ATPases. It has special type of, what are these pumps? Calcium ATPases. What is the function of this calcium ATPases? That during the repolarization process, during the diastole, right, these calcium ATPases actively transport the extracellular excuse me, we have to correct it. What is the basic function of this calcium ATPase is that when myocardium is relaxing, right, during that time they are pumping the intracytosolic calcium. What is this calcium? This is in the cytosol, right? Intracytosolic calcium to the sarcoplasmic place, right? So we can say that these are calcium capturing mechanisms. What are these? Calcium ATPases. They will actively transport calcium from the cytosolic area to sarcoplasmic reticulum. So in this way, when this due to impaired performance by the exchanger, when calcium is retained into cytosol, it is immediately stored into sarcoplasmic reticulum. So the result is that in the sarcoplasmic reticulum, calcium concentration become very, very high. Did you know in sarcoplasmic reticulum how the calcium is stored? There are calcium binders. You want to know the name of that calcium binders? Sure. They sequester the calcium. There are special proteins here. I will show you. For example, this is the protein here. This protein has points here. And who will fit in these points? Calcium. Calcium will stick to these points. So this protein is calcium binding proteins. Or more truly we say these are calcium sequestering protein. These are calcium sequestering protein. So their name is very simple. Calcium sequestering proteins are called simply cal sequestrins. So we can say that sarcoplasmic reticulum is very rich in cal sequestrins, so that whenever pump bring the calcium in, calcium will get bound to cal sequestrin. Is that right? So if patient remains digitalized for longer time, it means in the digitalized cell sodium level is more, so naturally calcium level will become more due to impairment of this exchanger. That will lead to extra calcium loading into sarcoplasmic reticulum. And now whenever depolarization will come under digitalization action, there is more calcium loaded here. Now whenever depolarization will come, during depolarization sodium comes in. Is that right? Now let me tell you the mechanism of depolarization. Right, sodium comes in, then it is followed by, during the plateau phase, there is incoming. What is it? Incoming potassium is this, my friend. Potassium is going out and calcium is coming in. What is this calcium? Extracellular calcium. So during plateau phase of the action potential, extracellular calcium come in, and this extracellular calcium act as the trigger calcium. This calcium is acting as trigger calcium, and this will act on what? Sarcoplasmic reticulum. And when they will act on the sarcoplasmic reticulum, then calcium releasing channels will be opened in sarcoplasmic reticulum. This is called triggered calcium. And now, because it is overloaded with calcium, so it will release normal amount of calcium or extra amount of calcium. So as compared to normal situation, there's too much calcium released, right? So patient myocardial cells which are digitalized, right, these cells under the influence of digitalis retain more calcium stores in the sarcoplasmic reticulum, and on arrival of action potential, especially during the influx of trigger calcium, they release massive amount of calcium, and this calcium remaining story you must be knowing. Yes, this calcium will bind with the this calcium will bind. What is this thing? Right? This calcium will bind with troponin. This is troponin. This calcium will bind with the troponin, and troponin, this is, what is this? Tropomyosin. So when calcium will bind, the extra calcium will bind with extra troponins. Troponins will work more effectively and pull away the tropomyosin between the binding sites of myosin head and actin. So what really happens that this is pulled away, and when this is pulled away, right, actin-myosin interaction is more effective and there's stronger contractility. Is that right? So whenever digitalis eventually lead to more calcium loading and more calcium release during every systole, more calcium act more on the troponin and extra work on troponin, extra you can say changes in the tropomyosin, and there will be better interaction between the actin-myosin filaments, and that will lead to better contraction. And when there is better contraction, we say there is positive inotropy. So this is how digitalis work. Is that right? Now this section of digitalis is something which most of the doctors know. But there is one more action of digitalis only very good doctors know. Right? But that action is extremely important clinically. So what is the second action of digitalis? Now I'm about to be impressed by you. Up to now we have discussed that one action of the digoxin or digitalis is that it increases the intracellular calcium. What is the second action of digitalis, please? Yeah. Digoxin. It has two actions, right? One action which every doctor knows, every good doctor knows, that it increases intracellular calcium. It's a calcium loader, right? And due to this calcium loading, we can say that digitalis is a positive inotropic drug. Due to this calcium loading. What is the second very important action of digoxin? Yes. What is the second most very important action of digoxin? Yes, if you don't know, should I mention? Yeah. That is, this drug is, only very good doctor know this. This drug is also stimulant to vagus system. Right? So it is a vagotonic drug. Vagotonic drug. This increases the vagus tone. Now we'll see that if you know the both actions, you can really talk in very good way that what are the net action of digitalis on the heart. Let me draw heart here. This is SA node. This is AV node, and these are your conduction pathway. This is bundle of head and right bundle branch and left bundle branch. Now this is your heart. We have to see what are the actions of digitalis on your heart. Now we are going to see the actions of digitalis on the heart. You know that right vagus supplies the, what is this? Right vagus supplies SA node, and left vagus mainly supplies excellent. A little bit anatomy here. That left vagus supplies AV node. This is right vagus, and here is left vagus. Now, first the direct action on the heart, calcium loading. So, number one, it loads the calcium in directly. This drug loads the calcium in SA node. It loads the calcium in atria. It loads the calcium directly in, what is it? AV node. And it loads the calcium in Purkinje fiber, and it loads the calcium on contractile myocardium. Is that right? This is the direct action of digitalis. When digitalis work on SA node, it directly become loaded with calcium. Atrial muscle become loaded with calcium. AV node become loaded with calcium. Conduction pathway become loaded with extra calcium. And what is this? Contracting myocardium, ventricular myocardium also become loaded with calcium. These are direct action, right? Then there are indirect action. Indirect action are through neuronal system. That digitalis also stimulate vagus. So vagal activity is increased or decreased? And if vagal activity is increased, vagal activity mainly work on, yes, on SA node and AV node. Very little vagal activity on atrium and almost no vagal activity on ventricle. This point is very important, right? That sympathetic and parasympathetic action on heart, right? I will draw this black as sympathetic receptors. Sympathetic receptors are present on SA node. Sympathetic receptors. Sympathetic receptors are present on atrium. Please draw this diagram. Sympathetic receptors are present on AV node. Sympathetic receptors are present on, what is this? Conduction pathway. And sympathetic receptors are present on ventricular myocardium. Actually, adrenergic receptors are present all over the heart. The concept which I am trying to make, the adrenergic receptors are present all over the heart. So catecholamine, they have action on all the heart. Catecholamine has SA node action, atrial action, AV node action, Purkinje system action, and ventricular action. But this is the action of sympathetic nervous system. But parasympathetic nervous system has action on SA node. It has receptors on SA node. It has receptors on AV node. Very few receptors on atria, or almost no receptor on ventricle. Now what I'm trying to put in your mind, I'm trying to emphasize that when there is adrenergic activity, right, it will change the activity of, enhance the activity of SA node, atria, AV node and ventricles. But when there is parasympathetic activity will influence the heart mainly by action on SA node and AV node. Is that clear? So we can say that parasympathetic nervous system, we can say epinephrine or sympathetic nervous system has global action on heart. Write it down the word, that sympathetic nervous system has global action on heart. Epinephrine or norepinephrine or other sympathomimetic drugs like dopamine. But parasympathetic nervous system has only selected or limited action on heart, only on SA node and AV node. Now look at this thing, that once you have understood this concept, now we see that calcium loading is a direct action. This is a direct action of digoxin on the myocardium. But vagotonic action is indirect. By changing the vagal tone, it changes the cardiac function. Now, vagus is SA node stimulator or inhibitor? Inhibitor, yes, it is parasympathetic nervous system, and it means vagus is negative chronotropic. Vagus is negative chronotropic influence. Chronotropic influence. Is that right? And here left vagus is negative dromotropic influence. Dromotropic influence. Right? Right vagus is positive negative chronotropic. So it means that when right vagus is stimulated, SA node activity is reduced, and when left vagus is stimulated, and of course it is stimulated, it means AV nodal activity is reduced. Now you see one thing. The direct action, whenever any myocardial area is loaded with the calcium, it is stimulated. Now listen. The calcium which is put in SA node, it is trying to make it positive chronotropic. But direct loading of the calcium is positive chronotropic influence. But indirect vagal activity lead to negative chronotropic. And vagal activity dominates over SA node. So SA node will be under negative chronotropic, or SA node will be in a nutshell, SA node will be inhibited. In the same way, when calcium is loaded on AV node, calcium stimulates the AV node, but there is more action by the vagus, and vagal action dominates. Due to this reason, AV node is also inhibited. So we can say Digitalis, right, inhibits the SA node, inhibits the AV node. But when Digitalis load the calcium in atrial myocardium, and when Digitalis load the calcium in ventricular myocardium, right, there is no opposing action by vagus on atrial myocardium and ventricular myocardium. So atrial myocardium is stimulated and ventricular myocardium is also stimulated. So now you should say that due to its direct action, it stimulates atrial and ventricular myocardium. But due to indirect vagotonic influence, it inhibits the sinus activity and nodal activity. You get it? So this is the, you can say, the gist of understanding that when you digitalize the patient, right, due to its direct action, it is loading, it is stimulating atrial and ventricular myocardium, and due to its indirect vagotonic influence, it is, yes, it is inhibiting SC node and AV node. Now you look at it. The beauty of this concept is that if you develop, look, if you develop toxicity of this drug due to any mechanism, if you develop toxicity of digoxin, then toxic doses of digoxin will produce sinus bradycardias and nodal bradycardias, but it will produce atrial tachycardias and ventricular tachycardia. So what a funny situation. The same drug can produce bradycardia as well as tachycardia. So a patient, when it is heavily digitalized and if he develop toxicity, then what really happens, that sinus and nodal bradyarrhythmias will occur, atrial and ventricular tachyarrhythmias will occur. Let me tell you combination of this. Let me give you an example of this combination. If there's Digitalis toxicity, there is strong AV nodal inhibition and SC nodal inhibition, right? And if AV node is too much inhibited, right, can it take all the impulses down? No. So we can say when AV node is inhibited too much in toxicity, it will produce AV nodal blocks, because this is negatively dromotropic action, right? And AV node cannot take all the impulses down through the, from the atrium to the ventricle. Is that right? But it may produce, Digitalis will overstimulate, what is this? Overloaded with the calcium. So these are ectopic foci. You know, when calcium is too much loaded in atrial myocardium or ventricular myocardial cells, when calcium is too much loaded, then resting membrane potential become near to threshold. And then what happens, that these cells develop abnormal increased automaticity. And abnormal increased automaticity is called bathmotropic action. So what we can say, this is a very funny drug that by action here it produces negative chronotropy. By action here it produces negative dromotropy. By loading the myocardial cell, it makes them positive inotropic and positive bathmotropic. Because the mechanical action, mechanical advantages of loading the calcium, and there are electrical disadvantages of loading the calcium. So let's suppose that extra calcium in Digitalis toxicity produce atrial tachyarrhythmia. That will produce atrial, because atrial cells are overloaded with calcium, their resting membrane potential become less negative or more near to threshold. So ectopic foci may fire too much in the atrium, and there may be atrial, what is this, tachycardia. Now on ECG, if you find a patient who has atrial tachycardia with AV nodal blocks, right, they say it is digoxin toxicity until proved otherwise. This is the most classic presentation of digoxin toxicity. The most classical presentation of digoxin toxicity on ECG is that patient has supraventricular tachycardias with AV nodal blocks. You can understand that due to calcium loading, there are supraventricular tachycardia, and due to vagal activity, AV nodal inhibition, there is AV nodal block. So you can see this is a, on ECG you will find combination of tachyarrhythmia as well as bradyarrhythmia. Is that right? So when this combination is there, right, when this combination is there, then you should suspect Digitalis toxicity. Is that right? Again, let me repeat it, that
How about EKG? Can you tell me that?
on EKG what will happen? Let me tell you. Normally, first I will draw the normal EKG, and then I will show you this EKG with this pathological change? Yeah. We'll go into detail later, but I will just tell you only this one. That what really happens in ECG, that normal ECG is P wave. What is this? PR segment, then QRS, T. First I tell you what will be the changes. Listen, this is ST segment. ST segment is coming on ECG, and this P wave is making what? Atrial depolarization. ST segment is current passing through AV node. Write it down. P wave is due to atrial depolarization. ST segment is current passing through AV node. QRS complex shows depolarization spread in the ventricle. Depolarization spread in ventricle. And ST segment shows when plateau phase, when you can say all the ventricle is depolarized and no current is flowing. And T wave shows repolarization of ventricle. It shows repolarization of ventricle. Am I clear? Now, what is happening to the heart? Let's see on ECG. On a digitalized heart, SC node and AV node are stimulated or inhibited? Inhibited due to indirect vagotonic action. So first thing will be, when current is taking longer time from atria to go to ventricle, when you are digitalize the patient, vagus is inhibiting the AV node. If an AV node is inhibited, it will take shorter time to conduct the impulse down, or it will take longer time? Longer time. If it will take longer time, look at the ECG change. That P wave is coming at its time, but current is taking very long time. True. So then QRS will come. So what is happening? That ST segment is prolonged in the time scale. Or if you put P wave with it, this is ST segment. And if you put the P wave also with it, it becomes PR interval. So what will happen? PR interval will be shortened or prolonged? Prolonged. So patients who are digitalized, they may have PR interval prolonged. What is the cause of prolonged PR interval? Remember, ST segment has at the end of the P wave, at the beginning of QRS. But PR interval is at beginning of the P wave up to the beginning of QRS. So all those, this is a rule, all those phenomena and drugs which inhibit the AV node lead to PR interval prolongation. All the drugs which inhibit the AV node lead to PR interval prolongation. I hope you will remember that. Did you know what are those drugs? At least tell me one drug which can prolong the PR interval. Digitalis, right? Good. So one drug which can prolong the PR interval is Digitalis. What are the others? Look, draw it here. What are the drugs which are making it prolonged? One is Digitalis, Digoxin. What is the other? AV node conduction depend on calcium. So calcium channel blockers. Calcium channel blockers. Then AV node is stimulated by sympathetic system. If you inhibit, AV node will be slow. So beta blockers. Then there is a drug called adenosine. Right? Adenosine act on AV node and bring lot of potassium out of AV nodal cells. Adenosine act on the AV node and forces the AV nodal cell to lose potassium. Of course, if potassium come out, AV node will become too much inhibited and negative. So it will be, listen.
What's the last one?
Adenosine. Again, let me tell you. Digoxin by, write down the mechanism. Digoxin by increased vagotonic activity, right? Inhibit the AV node. Calcium channel blocker, block the calcium channel, so AV nodal action potential is inhibited. Beta blocker, reduce the sympathetic activity on AV node and AV nodal activity is inhibited. Is that right? You know, sympathetic activity also normally load the AV node with calcium. Yesterday we discussed. Then adenosine is a very short acting AV nodal inhibitor. Sometimes it is given when you want to inhibit the AV node for very short time. Adenosine, when it binds with AV nodal cells, it opens their potassium channels. So AV nodal cell will lose potassium, and if a lot of potassium come out of the AV nodal cells will become more electronegative. If normally they are minus 60 millivolt, now they will become more electronegative due to loss of cations. And if EV node become too much electronegative, can you stimulate it? No. So this is what adenosine does. It is also AV nodal blocker. So all these drugs are AV nodal inhibitor. And another mechanism is also AV nodal inhibitor. Look here. If you stimulate here, carotid massage, this will stimulate the vagal outflow. When you do carotid massage, it increases the vagal outflow. That also inhibits the AV node. So the one physical method I have mentioned, 4 group of drugs I have mentioned, which are AV nodal inhibitor. All of them will prolong PR interval. But right now we are talking about action of Digitalis on the ECG. So effect of the Digitalis on ECG we have talked about right now is that if this is our classical ECG, right? Now what really happens that this become very much prolonged. So we can say that due to vagal stimulation, digoxin inhibits the AV node, and due to negative chronotropic action, due to inhibition of AV node, current takes longer time, cardiac impulse take longer time to move from atrium up to ventricle, and PR interval is prolonged. Then another thing, this is PR interval. Another concept is QT interval. QT interval starts from the onset of the Q wave, QRS complex, and it goes up to the end of T wave, right? This is called QT interval. Is that right? Now QT interval means what? It is beginning of the QRS, it includes the ST segment, and it includes the T wave up to the end, QT interval. Now what is the clinical importance of this? Look here. QT interval signifies, the significance of QT interval is, it is telling you the spread of onset and spread of ventricular depolarization, the duration for which ventricle remains depolarized, and spread and termination of ventricular repolarization. So it means that QT interval is the duration from the onset of ventricular depolarization up to the termination of ventricular repolarization. Is that right? Clear? Now listen. I told you that when you are loading the cells with calcium, they become positive inotropic as well as they become positive clinotropic. In clinotropy, I told you that there is increased velocity of contraction. Is that right? There is increased velocity of contraction. Now QT interval, look here, can be modified by calcium load. When there is more calcium in the cells, QT interval shrink. Look here. Calcium make the cell, myocardial cell, more effective or less effective?
Less effective.
No. Calcium make the myocardial cell more efficient or less efficient? More efficient. That is why we are giving the calcium loading drug like digoxin. Right? So if you keep in your mind that calcium loading to the cell makes the myocardium more efficient, it means not only it will contract more efficiently, but it will undergo depolarization and repolarization more efficiently. And if this whole process is occurring more efficiently, it will take longer time or shorter time? If you are efficient, you take for some work longer time, shorter time? Shorter time. Now again, let me repeat it. Calcium loading make the myocardial activity more efficient. Is that right? Within physiological limits. After that, toxicity will start. Now, when you load the calcium more in myocardial cells, right, not only mechanical activity is more efficient, ventricular electrical activity is also more efficient. Due to that reason, the patient who are digitalized, there is more efficient depolarization and repolarization. So total the onset of depolarization time up to the offset of completion of repolarization time, this time should be increased or decreased? This should be decreased. So what really happens that QRST is reduced. Now look at it. Now look at the upper ECG pattern and lower ECG pattern. Upper has shorter PR, it is a normal PR and normal QT interval. Here, as compared to normal, after this is digitalized heart, as compared to the normal, what is happening? PR interval is prolonged, and as compared to the normal, QT interval is shortened. QT interval is shortened. Is that right? So, PR interval is prolonged and QT interval is shortened. Now I want to tell you some more thing. I will not go into detail of electrical changes, but almost every doctor knows that in ischemic heart disease, there is changes in ST segment and T wave. In ischemic heart disease, there are changes in ST segment and T wave. Is it easy to understand? Now, what happens in ischemic heart disease which makes the ST segment T wave to change? That is the current of injury. That is the current of injury. Current of injury during ischemic heart disease load the myocardial cell with calcium. Here Digitalis is also loading the cell with calcium. Now you draw a parallel in your mind as a concept. Ischemic heart disease. Ischemic heart disease. Right? It also loads the calcium. And Digitalis. It also loads calcium. Due to calcium loading in ischemic heart disease, ischemic heart disease cells are ischemic and the cell membranes are not working well, and extracellular cations like sodium and calcium may be loaded in the ischemic or injured or infarcted cells. Digitalis also lead to intracellular loading of sodium as well as calcium. So this thing is common in ischemic heart disease. Ischemic heart disease and Digitalis both load the cations. And here the cation loading is too much and we call it current of injury. And that current of injury produces changes in ST segment and T wave. That here T wave may be elevation or T wave may be inversion, you remember, or ST segment may go up or ST segment may go down. So we can say very simply, ischemic heart disease by loading the myocardial cell and producing the current of injury brings ST segment and T wave changes. Now look at the parallel here. Digitalis, even though there is no ischemia, but Digitalis is also loading the cells with sodium and calcium, so it will also change the ST segment and T wave. So do you think you need to remember it? It's very simple. So PR interval is prolonged, QT interval is shortened, and there are ST segment, and for example ST segment may be elevated or depressed and T wave may be inverted. Is that right? So there are three changes on the ECG classically. What are those changes? Due to AV nodal inhibition, there is PR interval prolongation. Due to more efficient depolarization and repolarization, QT interval is shortened. And due to calcium loading, cationic loading, ST segment and T wave changes are also seen there. Yes, Jamie. Is it clear? Right? Okay. After this, we will come to another concept. But before that, we'll take a break. Now we will talk about how the hemodynamic parameters are disturbed in heart failure and what is the impact of Digitalis on those hemodynamic parameters. Let's start with the very basic, that is the principles of Starling's law. You know that if you increase, here is end diastolic volume and here is cardiac output, right? And you know it that normally in a healthy heart, end diastolic volume is about 140 ml. In a healthy heart, first I will talk about healthy heart. End diastolic volume is about 140 ml. And we know in a healthy heart, if you keep on increasing end diastolic volume, it means you are filling the heart more. Heart has intrinsic regulation that more you fill in, more it produces output, right? So more you put the venous return, more you fill the ventricle, more you increase the end diastolic volume, there's more stretch on the myocardial fiber and there's stronger contraction. So we can say that in a healthy heart, within physiological limits, if you keep on increasing end diastolic volume, actually you are increasing the cardiac output. So this can go like this. This is the normal function curve, right? Now we have to see that in this normal function curve, what happens in heart failure, number one. And then we have to see how Digitalis correct the problem. First, look at the normal point where heart is operating. Heart is operating normally at this point. That in a healthy heart, end diastolic volume is about 140 ml and cardiac output is about 5 liters. Is that right? This is the normal operative point, suppose point A. Right? Now, if this healthy heart suffers with extensive myocardial infarction, or this heart is suffering with, suppose, chronic ischemic heart disease, repeated ischemia, do you think that then its power of contraction is increased or decreased? It is decreased. It means for a given end diastolic volume, it will produce less cardiac output. Is that right? So curve should go up or curve should come down? It should come down. So what really happens in cardiac failure, we can say this curve should be depressed like this. And in a failing heart with poor contractility at end diastolic volume of 140 ml, rather than producing 5 liter, it will produce maybe only 2 liters, suppose 2.5 liters. Cardiac output has dropped. So we can say that this is the cardiac failure. Point A was the healthy point and point B is the failing heart, right? So we can say that what has happened, the dynamics, hemodynamic performance of the heart has shifted from point A to B when there has been structural or functional defect in the myocardium and myocardial contractility has dropped. Yes, what's your question? Yeah, of course. This is, of course, a very good question by Jamie. He says, is it low output cardiac failure? Of course, it is low output cardiac failure because we have divided the cardiac failure into two categories. Yes, high output cardiac failure and low output cardiac failure, right? Digitalis is given only in low output cardiac failure and we are talking about low output cardiac failure. Now, right, yeah, most common cardiac failure is low output cardiac failure. Now, point A will shift to the point B. Now, cardiac output drop. Now, what will happen in a failing heart? Up to now, we have not given the drug. Now, it's of a failing heart. Here, cardiac output is less. If cardiac output is less, now you imagine my heart is pumping less blood. Carotid sinus is overfilled or underfilled? Underfilled. So, baroreceptor will fire. They will report to the central nervous system that blood pressure is falling, cardiac output is falling. From central nervous system, sympathetic activity will increase. So at the point B, as soon as cardiac output drops, there is activation of, yes, number one, sympathetic nervous system. Sympathetic activity is increased. This is one thing which will happen automatically. Second thing which will happen, that as soon as your cardiac output will drop, not only baroreceptors will increase the sympathetic activity, but do you think renal blood flow will be more or less? When cardiac output drop, renal blood flow will be more or less? It will be low. Blood flow, when cardiac output is less, blood flow going to the kidney is less. When kidney are underperfused, there is activation of renin, angiotensin, aldosterone system. So it means that star number 2 is that by acute drop in cardiac output, there is activation of renin, angiotensin, aldosterone axis. Is that right? Now we see what really happens. Let me draw here is the left heart and here is the right heart. Now, what really happens, that what will be the impact of sympathetic nervous system and what will be the impact of renin, angiotensin, aldosterone axis in the failing heart? Sympathetic nervous system will do one thing good and one thing bad. In the same way, renin-angiotensin system will also do few things good and few things bad. Now, what are the good points? Good point is, for example, when renin-angiotensin-aldosterone system is activated, aldosterone will retain the water. Aldosterone will retain the water and sodium. So it means body will retain salt and water after the onset of failure under the direction of aldosterone. This retained water will increase the blood volume. Right? Kidneys are under the effect of aldosterone. Kidneys are retaining salt and water. The salt and water will add to the blood volume. Blood volume will be increased. When blood volume is increased, of course, venous return is increased. Right? When venous return is increased, it means cardiac filling is increased. When cardiac filling is increased, it means end diastolic volume, which was 140, it may become more. Maybe it become 200 and more. So what really happens, that by activation of renin, angiotensin, aldosterone axis, especially aldosterone retains salt and water through renal mechanism. This retained salt and water increases your blood volume. This increased blood volume lead to increased venous return and increased cardiac filling. And this increased cardiac filling will increase, what is this? End diastolic volume. So it means now point B, right? After this compensatory mechanism will start shifting in this direction. Is that right? This is one thing. Secondly, sympathetic nervous system will increase the heart rate and also increase contractility, right? So that will increase, look, sympathetic activity will increase this axis a little bit. Look here, this was by the salt and water retention, and this was by the, what is this? There's some contraction increased by sympathetic nervous system, plus one thing more. Sympathetic nervous system is venoconstrictor as well as arterioconstrictor. But first I will talk about sympathetic nervous system will constrict the veins, as well as angiotensin 2 also constrict the arteries and veins. So it means when these mechanisms become operative, they constrict the veins. When there is venous constriction, can blood stay into veins? No, blood is pushed back to the central system. So due to venoconstriction also, due to sympathetic mediated venoconstriction and angiotensin 2 mediated venoconstriction, there is increased venous return. When there is more venous return to the heart, end diastolic volume will further increase. So why end diastolic volume is increasing? Number one, due to aldosterone mediated salt and water. Number two, that sympathetic nervous system and angiotensin 2 mediated, yes, with a venoconstriction. Is that right? This was good because end diastolic volume is increasing, and increase in end diastolic volume is associated with some increase in contractility. Now, but there is a few things which are happening bad. What is the bad thing which is happening? Yes, Abdul Salam. No, the very bad thing, sodium and salt retention in the beginning is good because it will increase the cardiac output. The bad thing is arterioles are constricting. Sympathetic nervous system constrict the arterioles. Angiotensin 2 constrict the arterioles. So, left heart, can it pump well into very much constricted arteriolar system? It is already filling heart, and now you increase the afterload, the load against which it has to pump, arteriolar constriction. So, the increase in cardiac output which we were expecting, that will be partly nullified by increasing arteriolar constriction. So by increasing end diastolic volume, we were expecting a big increase in cardiac output, but unfortunately the same mechanism constrict the arterioles and partly nullify the beneficial action. So cardiac output is increased only slightly, and now heart will shift from point B to, yes, where it is shifting? To point C. Now look at the point C. At point C, rather than 2.5 liter, now it is pumping 3 liter. There is some advantage. There is some advantage due to these compensatory mechanisms. But now heart is operating at higher end diastolic volume. Heart is operating at higher end diastolic volume, right? And compensatory mechanisms are operating. For a while, this is good. There is a slight increase in cardiac output. But in the long run, it is very, very bad. Why it is bad? Yes, Ahmed, can you tell me? It is bad.
It can cause like pulmonary edema or something, congestion because you have a lot of volume.
Okay, this is one reason. What other? In the long run, the most important thing which happen, look, pulmonary congestion is here as well as there. Yeah, it's more severe because fluid is retained. This is one thing. I'm asking why this all thing if it remains like this and heart keep on operating under strong neurohumoral compensatory mechanism, why it is bad for myocardium? Because heart will undergo progressive failure. Now I'll tell you why. The reason being that walls of the myocardium are under normal stresses or abnormal stresses. Walls of the myocardium are under normal stresses when they are operating here or abnormal stresses? The abnormal stresses. They are receiving too much fluid, they are unable to, and yeah, they are receiving too much fluid and they are pumping very less. This is a very bad thing, right? And this chronic abnormal stress alters the expression of the genes of the myocardial cells. Myocardial cells, genomic expression alters under chronic stress. This is a very important point to understand. And these cells start decreasing their myosin production. They start producing extracellular matrix more, and heart eventually become more, the myocardium will convert into poor quality myocardium. This is extremely important because these days they say we must do something, not only for short-term increase, not to be happy with short-term benefits of these things, the very long-term bad things due to these neurohumoral compensatory mechanism. What are the bad things? What are the real disadvantages? That if these neurohumoral compensatory mechanism operate for longer time, they increase too much stress on the wall of the myocardium, and under chronic stress, genomic expression changes and myocardium expresses less, you can say, effective contractile proteins. It expresses excessive amount of myocardial cell make extracellular matrix, which is not good for the heart, and we say due to neurohumoral chronic activation, myocardium will become a very, very poor type of myocardium. Is that right? This is the bad thing. This is the price you pay for. Neurohumoral compensatory mechanism. Write it down, one classical sentence. That sympathetic nervous system and renin, angiotensin, aldosterone system. They are neurohumoral compensatory mechanisms which are good in the initial stages of cardiac failure. But in the long run, they have a deleterious effect on the myocardium. That is why, these days, the doctors are very much concerned that they should give angiotensin converting enzyme inhibitors in cardiac failure. They are giving the patients with the, you can say, beta blockers, so that stress on the walls should be reduced. Another problem which occurs, that at this point, Laplace's law is not in the favor of the patient. You know what is Laplace's law? Laplace's law states that pressure generated by a cylindrical container is directly proportional to the tensions in the wall. When myocardium contract, when sarcomeres contract, they produce tension in the wall, and it is pressure generated is inversely proportional to the radius. Now look at it. This law is very important when you understand the cardiac failure and the action of the drugs in a failing heart. Pressure is required for the cardiac output. If there is no pressure generated in the lumen, there cannot be any cardiac output. So we need pressure building in the lumen to get the cardiac output. But to build the pressure in the lumen, we need good tension in the wall. So tension in the wall acting on the radius, right, eventually produces pressure. Now look, what is happening? Very bad thing. That as heart, from here it was a smart heart, right? As heart is failing, neurohumoral mechanisms are retaining salt and water and increasing the venous return, and end diastolic volume is increasing. So what is happening to radius? Increase. So what is happening when heart is moving from this point to this, from B point, heart shift to the C point, during this process, it is progressively increasing its radius. It is progressively increasing its radius. Right. So with the given tension, no, the word we should use, with the given tension, the myocardial power to produce tension at point B and C, if tension power is the same, increasing radius decreases the pressure. So do you think it's good for heart or bad? Very bad. So actually, what really happens, neurohumoral mechanisms are good initially, but progressively they lead to dilated heart. And dilated heart has a bigger radius. And when it has a bigger radius, larger radius, with the given tension which myocardium can produce, failing myocardium can produce, it is producing lesser pressures. Right? At the top, you are producing arterioconstriction. So it's a big trouble. Now heart is here. Now we see what happened with Digitalis. You give the Digitalis, you digitalize your patient, right? When you know that Digitalis will eventually, we have discussed into detail how it will load the myocardial cell with calcium and how troponin tropomyosin will be acting and how actin-myosin interaction will start and heart contractility will increase. Now here we give Digitalis at point C. What we have introduced? Digoxin. Once the person is properly digitalized, for a given, now listen, for a given end diastolic volume, for example, now it is 240 ml. Patient has end diastolic volume of 240 ml and then you digitalize, it was a dilated heart, as cardiac output will now, under the influence of Digitalis, will decrease or increase? Increase. So it means after the digitalization, for a given end diastolic volume, cardiac output should go up. Now look at it. This is what is happening. So patient will shift from point C to point D. Right? For every given end diastolic volume, cardiac output will increase. So it means this will be the curve. Okay, we can make the D up to here. This is what average doctor will tell you. But you have to learn more than this. That how Digitalis will bring further changes. This is what everyone can understand. You digitalize the patient, this positive inotropic action, and from point C, it will shift to the point D. But the true story goes beyond it. What is the true story? Look, at 240 ml of end diastolic volume, heart is pumping more efficiently. Heart is able to produce less tension or more tension. So Digitalis, put the digoxin here. Digoxin has increased the power tension in the wall. Now, when tension will increase in the wall, pressure will be increased. When pressure will be increased, cardiac output will increase, then ejection fraction will increase. Now look here. Heart will contract more strongly. So it will throw more stroke volume out. And if heart is throwing more stroke volume out, after the digitalization, if heart starting throwing more stroke volume out, so what will happen? That end diastolic volume will start reducing. Heart will become more dilated or less dilated? Less dilated. So look at the beauty, that mechanism will start moving backward. Now I will tell you how this beautiful thing happens, and somewhere heart adjusts here at this point. Now look, this is the star point. Now truly what Digitalis did, the direct action of Digitalis was that due to positive inotropy, it took the dynamics from point C to D. Is it clear? But due to this increased contractility and increased cardiac output, other deleterious effects or bad effects will be reduced. How? Listen. First of all, when cardiac output will increase, renal perfusion will increase. When renal perfusion is increased, renin, angiotensin, aldosterone excess start relaxing. When it starts relaxing, salt and water retention become less. When salt and water retention become less, it means because there's less aldosterone, salt and water start washing out. So when salt and water is less in the body, then blood volume is less, then venous return is less, and when venous return is less, then end diastolic volume is less. So at D point, what really happened? You can write here that increased renal perfusion, relaxation of renin, angiotensin, aldosterone excess, less salt and water retention, less venous return, dynamics move backward. Number one. Number two. course, when cardiac output will increase, then baroreceptor stimulation for sympathetic nervous system is decreased. So sympathetic nervous system also relaxes. Renin, angiotensin, aldosterone system also relaxes. So compensatory mechanisms are relaxing. Now it's very easy to understand. When sympathetic nervous system will relax, venoconstriction will be less. When angiotensin 2 is relaxed, reduced, then venoconstriction is also less. So reduced sympathetic outflow after increasing the cardiac output at point D, there's reduction in sympathetic outflow, there's reduction in angiotensin 2 level. Both things reduce the constriction. Veins dilate. When veins dilate, my friend, veins will accommodate more blood. So venous return is reduced. When venous return is reduced to the heart, cardiac filling is reduced. When cardiac filling is reduced, now there are three mechanisms you should explain that at point D cardiac filling will start reducing. One reason that at D point salt and water retention is less and venous cardiac filling is less. Number two, venodilatation is there, right, due to sympathetic relaxation and angiotensin 2 relaxation. So less venous return. Now look at the beauty. When less venous return is there, radius is reducing. And when radius is decreasing, it's a good news or bad news? It's excellent news. We want the pressure generation. And now Digitalis Digitalis directly increases the tension and indirectly by relaxing the neurohumoral mechanism, it decreases the radius. And when radius will decrease, increasing tension and decreasing radius, the pressure generation will be less or more? Increased. Is that right? That is a secondary effect it produces. The story is not yet over. The very important point, the most wonderful point, that sympathetic nervous system when it goes down and angiotensin goes down, arterioles relax. And when arterioles relax, the pressure required to maintain the cardiac output is more or less? Listen, if arterioles relax, now heart is beating against more resistance or less resistance? Less resistance. So it has to generate less pressures. So now the whole dynamics are changed in Laplace's law. Pressure, tension over radius. Now go step by step. When you digitalize the patient, first tension went up. Look at, you have to talk about all these three things. The tension went up. When tension went up, cardiac output became more. Right? It was able to produce more pressure. So the result was here, there was more pressure. When pressure generated were more, cardiac output was more, sympathetic nervous system started relaxing, renin-angiotensin system started relaxing. So sodium load in the body is reduced and venodilatation is there. So blood volume is reduced and venous pooling is more, venous return is less, so radius is reduced. Right? When radius is reduced, now increasing tension, reducing the radius produces very efficient pressure. This was increase in pressure due to increased tension. This is increase in pressure due to reduced radius. So dilated heart turn back to smarter heart. And smart heart is more efficient heart. Is that right? Now look at it. Now pressures you are generating more. But the pressures are required to overcome the resistance against the blood flow in the arterial tree. The pressures were required for what purpose? So that you can maintain cardiac output to the peripheral tissue. That was the purpose. Na? But when sympathetic nervous system went down, when angiotensin 2 went down, even arterioles relax. So with this pressure, blood flow will be really very good and cardiac output will be maintained excellently. So what really happens, now here where it was originally 140 ml, it went to 240 ml, now it is about, for example, 180 ml. Now at the end diastolic volume of 180 ml, let's suppose it is maintaining 4 liter. Dynamics are not normal, but close to normal with less, you can say, retention of salt and water.
Basically, all these phenomena is occurring, and then it's the Digitalis reversing it.
Yeah. First, look at it. This was a healthy heart. Attention. This is a healthy heart. First, cardiac output dropped. Then end diastolic volume progressively increased. Then it took the cardiac output up and reduced the end diastolic volume. Is that right? This is the how Digitalis alters your hemodynamic parameters of cardiovascular system. Am I clear? At this stage, when heart is operating at B stage, we say there is cardiac failure but uncompensated. This is cardiac failure uncompensated. But here, when neurohumoral mechanisms are activated, it is still failing at point C, but it is compensated failure. So this is say that there is at point C, there is compensated cardiac failure. Is that right? So this is what we have integrated. Now if there's any MCQ like this, you can handle with.
But right there, number C, all the sympathetic activity is going on.
Yeah, there's very high sympathetic activity and there is a high renin, angiotensin, aldosterone activity. It is good for a while, it is very bad in the long run. Why it is very bad? Because with this sympathetic activity, there is strong tension on the stress on the walls. Then too much fluid retained and dilated heart, strong stresses on the wall. Then angiotensin 2 and sympathetic nervous system constricting the arterioles. Failing heart, already donkey is tired. At the top you are forcing it to go against resistance. Is that right? So this thing has done initially beneficial by increasing end-diastolic volume, but bad thing, all these things increase the stress on myocardium. And if failing heart, myocardium keep on working under high stress, it becomes progressively failing mechanism. Is that right? So this is what we have achieved with this thing. Now something interesting. In cardiac failure, initially we use diuretics and we use angiotensin converting enzyme. Let me tell you, integrate those drugs action on the same, what is this, graph. Let's suppose your heart is operating here and you are a patient with heart failure and your doctor does not give you Digitalis. He says, let me try first diuretics.
It's not going to work.
No, it is going to work. Let's see how. Why to go up and come down? Why don't you move like this? I will tell you exactly how it happens. For example, I give my patient with a cardiac failure angiotensin converting enzyme inhibitor like captopril or enalapril. Right now we are giving the drugs renin, angiotensin, aldosterone axis system. I needed to relax. Is that right? Or we can say simply the drugs which I am giving, I'm not trying. You are at patient is operating at this point, but this time I'm not going to give digoxin. This was action of digoxin, direct action and then indirect action. This time I'm going to give angiotensin converting enzyme inhibitor. Now listen what will happen. When you give angiotensin converting enzyme inhibitor, then angiotensin 2 level in the body become less or more? Less. And aldosterone level become less. So what really happens when you give this drug, and of course with that I have to give diuretics. Right? So we are reducing the aldo, we are reducing the angiotensin 2, and with diuretic we are reducing salt and water load. Now you imagine. These two drugs we introduce at this point. What will happen when salt and water is less? When salt and water is less, it should move in this direction. Is that right? And when angiotensin 2 is less, veins will dilate. It will still move in this direction. Is that right? It means that when we are giving this drug, angiotensin converting enzyme inhibitors and diuretic, actually we are reducing, diuretic reduces the total blood volume. And when total blood volume is there, that will lead to what? Now Laplace's law with the new drugs. We give diuretic. Total salt and water is reduced. So total venous return is reduced. And what will happen? Radius of the heart will reduced. So this is the advantage of diuretics. Now we look at the angiotensin converting enzyme inhibitor, effect on the Laplace's law and effect on the graph. The angiotensin converting enzyme inhibitor, number one, reduce aldo. Again, aldosterone is reduced, so salt and water is reduced. So radius is further reduced. And both these things will move it towards backward. This is one thing. Secondly, when angiotensin 2 is reduced, then constriction is reduced, veins dilate. When veins dilate, less venous return going. Again, radius is reduced. You get it? Again, radius is reduced. It means that if progressively radius is reducing, with the given tension, pressure generated are more. Are you understanding? Because we are reducing the radius of the heart, So with the same contractility, we have not given any positive inotropic agent. So with the same filling tension, when we reduce the radius, heart start producing better pressures. When it does better pressure, so it start increasing cardiac output. So it means that this will not truly move like this. Actually, it will initially move like this. Is that right? It's moving like this. Am I clear? Then something will happen. What is that? That when cardiac output pressures are more, cardiac output is more, sympathetic nervous system will relax. Arterioconstriction will relax. Angiotensin 2 is less, that will also further relax the arterioconstriction. So when most of the arteries will relax, what will happen? The resistance against which heart has to pump is less. So at given end diastolic volume, heart will produce more ejection or less ejection if arterioles are relaxed.
Less ejection.
Listen again. No, let me repeat it. You people are set. Again, concentrate. We gave diuretics and angiotensin converting enzyme inhibitor. They reduce the blood volume, reduce the radius of the heart. They relax the veins, right? So again, cardiac filling was less, radius was less. Is that right? So when radius was less for a given tension, it could produce more pressure. If it was producing more pressure, then cardiac output is more. When cardiac output is more, that further reduces the intrinsic, you can say, sympathetic outflow. Sympathetic outflow was high due to low cardiac output. When cardiac output will go up, sympathetic system will relax. Now arterioles will relax. When arterioles will relax, now the same pressure will produce more cardiac output, and at the same end diastolic volume, cardiac output will be more, and it will jump like this. We reach to the same point. Now the clinical saying is that when a patient comes with heart failure, first use these drugs. And if they are not enough, still patient develops symptoms, then you come for digoxin. You know why? The reason being, digoxin has a lot of toxicity. These drugs are not so toxic. Angiotensin converting enzyme inhibitors and diuretics are less toxic drugs. Digitalis has high risk of toxicity. This is one reason that due to concern about the safety of the drugs, rather than going through this route, rather than going from route number C to D, then to star point, it's better to come from C to, let's suppose, E, and then to the star point. The safer route. The route, look, you can reach at star performance of the heart through this unsafe route, or you can come through safe route. Am I clear? And actually, another beauty, that truly this route goes very fast when you use angiotensin converting enzyme inhibitors and diuretic. Truly this route goes like this. Because as soon as end diastolic volume is reducing, pressures are increasing and cardiac output is increasing. So for explanatory purpose, you can say that vector backward, then vector upward. But the net vector is upward and backward. So this is a combination of use of diuretics and angiotensin converting enzyme inhibitors. Is that right? These are the safer drugs, number one. Number two, the long-term survival is increased in patients who are on diuretics and angiotensin converting enzyme inhibitor. The reason being that these drugs reduce that tension on the wall. You know, aldosterone level when they're high, now they've discovered a new thing. Average doctor knows that aldosterone work on kidney, but excellent doctor knows aldosterone at high concentration disturb the genetic expression of myocardium. Now they know. Every doctor knows that angiotensin 2 work on veins, angiotensin 2 work on arteries, angiotensin releases aldosterone, right? Angiotensin produces thirst, angiotensin work on kidney somewhere directly, but excellent doctor knows that if chronically high angiotensin 2 is there, it will disturb the myocardial genetic expression. That is, yeah, so neurohumoral compensatory mechanisms are bad in the long run for the heart, right? Because high aldosterone and high, look, there are two things. Number one, they produce the tension on the wall. It stresses on the wall. They were bad. Number two, at this point, elevated level of aldo and elevated level of angiotensin 2. They disturb the myocardial cells genetic expression. So these days they say that angiotensin converting enzyme inhibitors and diuretic, right, they are excellent, that not only they correct the hemodynamic, they reduce the aldo level and reduce the angiotensin 2 level and reduce the pathological remodeling going in the myocardium. Is that clear? So what is the principle? When a patient comes with heart failure, it's better to give first ACE inhibitors, diuretics, and in some situations beta blocker. If all of them don't work well, then you go for Digitalis. Why Digitalis is left at the end? Because a good drug but with a lot of bad side effects.